Welcome. If you watched our last video, you'll remember we broke down the anatomy of the forearm and hand bones, covering the radius, ulna, carpals, and metacarpals in a simple way. Today, we're building on that knowledge, so let's get started. We're diving into the fascinating anatomy of the pectoral region, the area that forms the front of your chest. This region is not only crucial for connecting your upper limbs to your torso, but it also houses the mammary gland, an essential structure especially in females. Whether you're a student, a healthcare professional, or just curious about how your body works, understanding the pectoral region is foundational. We'll explore its surface landmarks, the underlying structures, and the unique features that make this area so important. Let's start our journey by getting familiar with what exactly the pectoral region is and why it matters. Pectoral region is found on the front of the chest and acts as a connection between the upper limb and the chest wall. This area isn't just made up of muscles and bones, it contains an intricate arrangement of tissues, nerves, and blood vessels that work together. The mammary gland, which is more developed in females, is also located in this region. Knowing the boundaries and structures of the pectoral region helps us understand its role in movement, protection of underlying organs, and nourishment of newborns. In the next part, we'll focus on the surface features you can see and feel that help identify the pectoral region on the body. Better understand the pectoral region, we first need to identify its surface landmarks. These are structures you can see or feel on your own body. One of the most noticeable landmarks is the clavicle or collarbone, which runs horizontally at the base of the neck and separates the neck from the chest. You can easily feel it along its entire length, where it connects medially to the sternum and laterally to the acromion of the scapula. Between the inner ends of the clavicles is a small depression called the jugular notch. About 5 centimeters below this is the sternal angle, which marks the junction between the manubrium and the body of the sternum. These surface landmarks are important not only for understanding anatomy, but also for guiding clinical examinations and medical procedures. Clavicle plays an important role in the pectoral region and sits just beneath the skin, which makes it easy to trace with your fingers from one end to the other. On its inner or medial side, the clavicle connects to the sternum at the sternoclavicular joint. On the outer or lateral side, it attaches to the acromion of the scapula at the acromioclavicular joint. Because the ends of the clavicle project slightly upward, both of these joints can usually be felt through the skin. However, the sternoclavicular joint may sometimes be partially covered by the sternocleidomastoid muscle, making it less obvious. These joints are essential for proper shoulder movement and stability, and they also act as useful landmarks for locating other structures in the pectoral region. The jugular notch, also called the suprasternal notch, is a small visible hollow at the top of the sternum, located between the two clavicles. If you move your fingers slightly downward from this point, you'll feel a raised ridge across the chest known as the sternal angle or the angle of Louis. This landmark is especially important because it marks the junction between the manubrium and the body of the sternum, and it is where the second rib attaches. Once the sternal angle is identified, the remaining ribs can be counted moving downward. This makes it a key reference point during physical examinations and many clinical procedures. As we move further down the chest, we come to the epigastric fossa, commonly called the pit of the stomach. This is a small depression located at the infrasternal angle just above the xiphoid process. It is bordered on either side by the 7th costal cartilages, which help define this region. Another important surface landmark is the nipple. Its exact position can vary, particularly in females, but in males and immature females, it is typically located in the 4th intercostal space, slightly medial to the midclavicular line. These landmarks are useful not only for learning anatomy, but also in clinical practice, for example, when estimating the position of the heart or guiding certain medical examinations and procedures. Midclavicular line is an imaginary vertical line drawn straight down from the midpoint of the clavicle. It passes over important surface landmarks, including the tip of the 9th costal cartilage and the midinguinal point. Although it isn't a physical structure, this line is widely used as a reference for describing the position of organs and other anatomical features. Beneath the clavicle is a shallow depression called the infraclavicular fossa, also known as the deltopectoral triangle. This triangular area is bordered by the pectoralis major muscle on one side, the front fibers of the deltoid muscle on the other, and the clavicle above. Together, these surface lines and depressions are important in both anatomy and clinical settings, as they help clinicians locate underlying structures and safely guide medical procedures. The coracoid process is a small bony projection of the scapula, and its tip is located about 2 to 3 centimeters below the clavicle. It is partially covered by the deltoid muscle, so it isn't immediately visible, but it can be felt with deep palpation just lateral to the infraclavicular fossa. Another important scapular landmark is the acromion. This structure forms the highest point of the shoulder and is easy to feel beneath the skin. The back end of the acromion is known as the acromial angle, and the acromion connects to the clavicle at the acromioclavicular joint. Together, these bony landmarks are key to understanding the structure of the shoulder and are commonly used when assessing or diagnosing shoulder injuries. Deltoid is a large triangular muscle that forms the rounded shape of the shoulder. Its pointed end faces downward, and the muscle extends from the acromion of the scapula to the deltoid tuberosity on the humerus. Because of its position and size, the deltoid plays a major role in shoulder movement and arm elevation. Axilla, commonly known as the armpit, is a pyramid-shaped space located between the arm and the chest wall. When the arm is raised, the floor of the axilla moves upward and the surrounding folds become more noticeable. The front or anterior axillary fold is formed by the lower edge of the pectoralis major muscle, while the back or posterior fold is created by the tendon of the latissimus dorsi. These surface features are important for understanding how the arm moves and are frequently examined during clinical assessments. Medial wall of the axilla is formed by the upper four ribs, which are covered by the serratus anterior muscle. This wall lies against the side of the chest. In contrast, the lateral wall of the axilla is much narrower and is made up of the upper part of the humerus, covered by the short head of the biceps brachii and the coracobrachialis muscles. Pressing the axillary artery against the humerus, its pulsations can be felt, making this an important site for checking circulation. The cords of the brachial plexus can also be gently rolled against the humerus during examination. In addition, the head of the humerus can be felt by pressing the fingers upward into the axilla. These palpation points are especially important during clinical assessments, such as evaluating trauma or examining blood vessel. Mid-axillary line is an imaginary vertical line that runs right between the front anterior and back posterior axillary folds. While you can't see it on the surface, it's a key reference in clinical practice, often used to locate structures or guide procedures like chest tube insertion. This line is especially helpful when other surface landmarks are hard to identify. By understanding the mid-axillary line and the surrounding folds, clinicians can more accurately examine and treat conditions affecting the chest and upper limb. Beneath the skin of the pectoral region lies the superficial fascia, a layer containing moderate fat and continuous with surrounding areas. This fascia is especially important because it houses the mammary gland, which is well developed in females. The fibers septa from the fascia support the gland's lobes and the overlying skin. Besides fat, the superficial fascia contains cutaneous nerves, blood vessels, the platysma muscle, and the breast. This layer is the first encountered during surgical procedures or dissections. Superficial fascia of the pectoral region isn't just fat. It also contains cutaneous nerves from the cervical and intercostal nerves, cutaneous branches from the internal thoracic and posterior intercostal arteries, the platysma muscle, and the breast. Each of these components plays a role in sensation, blood supply, movement, and support. Understanding what's inside this layer helps explain how the chest wall functions and how it responds to injury or disease. Dissecting the pectoral region, specific points and lines are marked to guide incisions. These include the center of the suprasternal notch, the xiphoid process, the areolar margin, and the lateral end of the clavicle. Incisions are made vertically, laterally, and horizontally to reflect the skin flaps and expose the underlying structures. This methodical approach ensures that important anatomical features are preserved and clearly visible during study or surgery. Pectoral region skin receives its nerve supply from several sources. The medial, intermediate, and lateral supraclavicular nerves, branches of the cervical plexus, supply the upper half of the deltoid and the area from the clavicle to the second rib. The interior and lateral cutaneous branches of the second to sixth intercostal nerves supply the skin below the second rib. The intercostobrachial nerve from T2 supplies the floor of the axilla and the upper medial arm. These nerves are important for sensation and can be affected in injuries or surgeries. Interesting feature of the pectoral region's nerve supply is the way dermatomes, or skin areas supplied by specific spinal nerves, are arranged. The areas supplied by C3 and C4 meet those supplied by T2 and T3, with little overlap because the intervening nerves C5, T1 are pulled away to supply the upper limb. Normally, adjacent dermatomes overlap, but here, the unique arrangement is due to the functional demands of the arm and chest. This knowledge is crucial for understanding patterns of sensory loss or referred pain. Cutaneous vessels in the pectoral region are generally small. The interior cutaneous nerves are accompanied by perforating branches of the internal thoracic artery, which are especially large in females to supply the breast. The lateral cutaneous nerves are accompanied by lateral branches of the posterior intercostal arteries. These vessels are important for nourishing the skin and underlying tissues, and their arrangement is relevant in surgeries and trauma care. Platysma is a thin, broad sheet of muscle that lies just under the skin. It arises from the deep fascia over the pectoralis major, runs upward and medially across the clavicle and neck, and inserts into the base of the mandible and the skin of the lower face. Supplied by a branch of the facial nerve, the platysma contracts when the mouth is pulled down, wrinkling the neck skin. It may also protect the external jugular vein from pressure. This muscle is important for facial expressions and neck movement. The breast, also known as the mammary gland, is the most important structure in the pectoral region. Although it is present in both males and females, it remains underdeveloped in males and becomes fully developed in females after puberty. Structurally, the breast is a modified sweat gland and functions as an accessory organ of the female reproductive system. Its primary role is to produce milk, which provides essential nutrition for newborns. Because of its detailed structure and vital function, the anatomy of the breast is especially important to understand, particularly in medical and surgical practice. The breast lies within the superficial fascia of the pectoral region. For anatomical and clinical purposes, it is divided into 4 quadrants: upper medial, upper lateral, lower medial, and lower lateral. There is also a small extension of breast tissue known as the axillary tail of Spence, which passes through the deep fascia and extends into the armpit or axilla. Dividing the breast this way makes clinical examination easier and allows healthcare professionals to accurately describe the location of any lumps, lesions, or other abnormalities. Vertically, the breast extends from the 2nd rib down to the 6th rib. Horizontally, it reaches from the outer edge of the sternum to the midaxillary line. Knowing these boundaries is important for clinical examinations, surgical planning, and understanding how diseases of the breast can spread. One area of special importance is the axillary tail, which extends into the armpit and is carefully examined during breast cancer assessments. The deep surface of the breast rests on the pectoral fascia, which covers the pectoralis major muscle. Beneath this layer are parts of the pectoralis major itself, the serratus anterior muscle, and even the external oblique muscle of the abdomen. The breast is separated from the pectoral fascia by a layer of loose connective tissue called the retro-mammary space. This space allows the breast to move freely over the chest wall, which is important for normal movement and is also very helpful during surgical procedures. Skin covering the breast has several distinctive features. The nipple is a small, cone-shaped projection located slightly below the center of the breast, usually at the level of the 4th intercostal space. It contains about 15 to 20 lactiferous ducts that open onto its surface, along with smooth muscle fibers, and it is richly supplied with nerve endings, making it highly sensitive. Surrounding the nipple is the areola, a circular area of darker, pigmented skin. The areola contains specialized sebaceous glands that become more noticeable during pregnancy and breastfeeding. These glands form small bumps called the tubercles of Montgomery, which release an oily substance that helps lubricate and protect the nipple during lactation. Areola is the circular, pigmented skin surrounding the nipple and is rich in specialized sebaceous glands. During pregnancy and breastfeeding, these glands enlarge and appear as small raised bumps called Montgomery's tubercles. They produce an oily secretion that keeps the nipple and areola lubricated, helping prevent cracking during breastfeeding. In addition to these glands, the areola also contains sweat glands and small accessory mammary glands. Unlike most skin, it does not contain hair or underlying fat. Just beneath the areola are the lactiferous sinuses, which temporarily store milk before it is released during feeding. The functional tissue of the breast, known as the parenchyma, is a compound tubulo-alveolar gland that produces milk. It is made up of about 15 to 20 lobes, and each lobe contains many small clusters of alveoli where milk is actually formed. Each lobe drains into a lactiferous duct, and these ducts gradually come together as they travel toward the nipple. Just before reaching the nipple, each duct widens to form a lactiferous sinus, which acts as a temporary storage area for milk. During lactation, the structure of the gland changes noticeably. The epithelial cells lining the alveoli become larger and more active, reflecting their increased role in milk production. When the breast is not actively producing milk, the cells lining the alveoli are mostly cubital in shape. During lactation, these same cells become taller and more column-shaped to support milk production. In alveoli that are filled and stretched with milk, the cells can still look cubital, but they are noticeably larger than they are in the resting state. The smaller ducts are lined with columnar epithelial cells, while the larger ducts have several layers of cells for added support. As the ducts approach the nipple, their lining changes to a tough, stratified squamous epithelium to protect the opening. Surrounding both the alveoli and the ducts are myoepithelial cells which contract and gently squeeze the milk, helping push it along toward the nipple. Stroma of the breast provides its supporting framework and is made up of both fibrous and fatty tissue. The fibrous part forms strong connective tissue bands called the suspensory ligaments of Cooper. These ligaments extend from the skin down to the pectoral fascia, helping anchor the breast and maintain its overall shape. Fatty component makes up most of the breast tissue, except in the areas directly beneath the nipple and areola. Together, this combination of fibrous and fatty tissue gives the breast its contour, flexibility, and support. Changes in the stroma, such as loss of fat or tightening of ligaments, can noticeably affect the appearance and function of the breast. Mammary gland has a rich blood supply, receiving arteries from several sources. The internal thoracic artery, which branches off the subclavian artery, sends perforating branches to the breast. Additional blood comes from branches of the axillary artery, including the lateral thoracic, superior thoracic, and acromiothoracic arteries, as well as from the lateral branches of the posterior intercostal arteries. Most of this blood reaches the breast from the front, while the back of the breast has fewer vessels. Knowing this pattern is important for planning surgeries and managing breast diseases effectively. Veins of the breast generally follow the path of the arteries and form a network at the base of the nipple called the venous circle. From this circle, veins branch into superficial and deep sets. The superficial veins drain into the internal thoracic vein and the veins of the lower neck, while the deep veins drain into the axillary and posterior intercostal veins. This venous network is clinically important because it helps explain how infections or cancer cells can spread from the breast to other parts of the body. The breast gets its nerve supply from the anterior and lateral branches of the 4th to 6th intercostal nerves. These nerves carry sensory signals from the skin and autonomic signals to the smooth muscles and blood vessels. They do not, however, control milk production that is regulated by hormones. The dense nerve supply is why the nipple and areola are so sensitive, which is important for breastfeeding and protective reflexes. Although the nerves provide sensation and control some blood vessels and muscles, milk production is regulated by the hormone prolactin. Prolactin is released by the anterior pituitary gland and stimulates the glandular tissue of the breast to produce milk, particularly after childbirth. Knowing how prolactin works is important for understanding breastfeeding, as well as for managing certain breast conditions and disorders. The lymphatic system of the breast is crucial in breast cancer because most cancers spread through these vessels to nearby lymph nodes. Understanding these drainage pathways helps doctors plan surgeries and anticipate how the disease might spread. Lymph nodes and vessels not only drain fluid, but also play an essential role in the body's immune defense. Lymph from the breast drains into several groups of lymph nodes. The axillary lymph nodes, especially the anterior or pectoral group, receive most of the lymph. Other groups, including the posterior, lateral, central, and apical nodes, also play a role. Additionally, the internal mammary peristernal nodes, supraclavicular nodes, cephalic deltopteral node, posterior intercostal nodes, and subdiaphragmatic and subparietal plexuses can receive lymph from the breast. This complex network is crucial for understanding the spread of infections and cancer. The lymphatic system of the breast is crucial in breast cancer because most cancers spread through these vessels to nearby lymph nodes. Understanding these drainage pathways helps doctors plan surgeries and anticipate how the disease might spread. Lymph nodes and vessels not only drain fluid, but also play an essential role in the body's immune defense. About 75% of lymph from the breast drains into the axillary nodes, mainly the anterior group. Around 20% goes to the internal mammary nodes and 5% to the posterior intercostal nodes. Among the axillary nodes, lymph flows from the anterior and posterior groups to the central and lateral groups, then to the apical group, and finally to the supraclavicular nodes. This distribution is important for staging breast cancer and planning surgical interventions. The internal mammary nodes or peristernal nodes are located along the internal thoracic vessels. They drain lymph from both the inner and outer halves of the breast. This is important because it means that cancer or infection from the outer breast can also reach these nodes. Knowing this drainage pattern helps doctors plan imaging and surgical procedures more effectively. Axillary lymph nodes are divided into several groups: anterior pectoral, posterior lateral, central, and apical. The anterior group is closely related to the axillary tail of the breast and receives most of the lymph. Lymph from the anterior and posterior groups passes to the central and lateral groups, then to the apical group, and finally to the supraclavicular nodes. This stepwise flow is important for understanding the progression of breast cancer and planning lymph node dissection. Pattern of lymphatic drainage explains why breast cancer often spreads first to the axillary lymph nodes. Surgeons and oncologists use this knowledge to check for metastasis and plan treatments. Sentinel lymph node biopsy, for example, targets the first node in the drainage pathway to assess cancer spread. Understanding these pathways is crucial for early detection and effective management of breast cancer. In summary, the pectoral region is a complex area linking the upper limb to the chest wall and containing the mammary gland. Its surface landmarks, muscles, nerves, blood vessels, and lymphatics all contribute to movement, sensation, and overall health. The breast itself has unique structures and functions with important clinical significance, particularly in breastfeeding and in the detection and management of breast cancer. Understanding this region is essential for anyone studying anatomy, medicine, or healthcare. Knowledge of the pectoral region's anatomy is not just academic, it has real-world applications. Clinicians use surface landmarks to guide procedures like injections, biopsies, and chest tube insertions. Surgeons rely on an understanding of nerves, vessels, and lymphatics to perform safe and effective operations. Even in everyday life, awareness of this region helps in injury prevention and self-examination for breast health. Several clinical conditions are associated with the pectoral region, including fractures of the clavicle, dislocations of the shoulder, infections, and tumors of the breast. Understanding the anatomy helps in diagnosing and managing these conditions. For example, knowledge of lymphatic drainage is crucial in breast cancer, while awareness of nerve supply helps in treating injuries and pain syndromes. Regular self-examination of the breast is important for early detection of lumps or changes that could indicate disease. Knowing the normal anatomy and landmarks helps individuals perform effective self-checks. Early detection of abnormalities, especially in the breast, can lead to better outcomes and less invasive treatments. Education about anatomy empowers people to take charge of their health. Let's recap the key points. The pectoral region is vital for connecting the upper limb to the chest and contains important structures like the mammary gland. Surface landmarks guide clinical practice, while the underlying nerves, vessels, and lymphatics are crucial for function and disease management. The breast's anatomy is especially significant for understanding lactation, cancer, and surgical procedures. As we move forward in our study of anatomy, the knowledge of the pectoral region will serve as a foundation for understanding the upper limb, thorax, and related clinical conditions. Whether you're preparing for exams, clinical practice, or just expanding your knowledge, mastering this region is a valuable step. Stay curious and keep exploring the wonders of the human body. Thank you for joining this deep dive into the pectoral region. We've explored its anatomy, surface landmarks, nerves, blood vessels, lymphatics, and the unique features of the breast. If you want to learn more, consider exploring related topics like the axilla, upper limb muscles, and the thoracic wall. A solid understanding of this region not only enhances your knowledge of anatomy, but also helps you appreciate the body's incredible complexity and resilience. If you enjoyed this video, don't forget to like and subscribe for more in-depth anatomy guides, tips, and explanations. Hit the bell icon so you never miss an update and leave a comment if there's a topic you'd like us to cover next.